Welcome to this high-yield explainer on toxoplasmosis. If you're an MBBS student gearing up for your exams, well, you're in exactly the right place. We're going to take the complexity out of Toxoplasma gondii and turn it into simple, totally recallable facts. Think mental frameworks, memory tricks, and mnemonics designed specifically to help you absolutely crush your microbiology boards. Okay, let's just take a quick peek at the agenda today. We're covering morphology, the life cycle, pathogenesis and clinical presentation, lab diagnosis, and finally, treatment and prevention. First up, Section 1, Morphology. Let's look at the actual forms of Toxoplasma. Go ahead and take a mental screenshot of what we're looking at here. Notice how visually distinct these three forms really are. Over on the left, you've got Tachyzoites with that classic crescent or comma shape. Right in the middle, you see the tissue cysts, and they are packed tightly with Bradyzoites. And then on the right, the oocysts, which hold those spore cysts. You really need to be able to recognize these instantly if they pop up in a clinical vignette. Now, here is your first major memory trick for the boards. Tachyzoites starts with a T, right? So just remember, they are active-tive. They're the actively multiplying form that you'll see in acute infections circulating in the blood. Bradyzoites, on the other hand, start with a B, so remember they take a break. They are the slowly multiplying resting stage tucked away in tissue cysts inside muscle and brain tissue during chronic infections. Finally, the oocysts. Those are the sexual form, and they're excreted exclusively in cat feces, so T for active, B for break. Definitely lock that one in.
Moving right along to Section 2, Life Cycle and Transmission.
This diagram brilliantly illustrates the parasite's whole empire. If you follow the arrows, you'll see Toxoplasma is pretty unique because it runs two distinct cycles. The feline cycle on the left happens in the definitive host, cats, where sexual reproduction happens, popping out those unspoilated oocysts in the feces. Then on the right, you've got the human cycle. Humans, along with rodents and some other mammals, act as intermediate hosts. So in us, only the asexual cycle takes place. That's where those tachyzoites multiply and eventually settle down as tissue cysts in organs like the brain. So how does it actually get into humans? Well, there are four main routes of transmission. I want you to circle the first point in your notes, literally draw a big circle around it, because ingestion of tissue cysts from undercooked meat is absolutely the most common route of transmission tested on the boards. Seriously, don't let them trick you into thinking it's always the cat litter. Though, to be fair, ingestion of sporulated oocysts from contaminated soil or water is the second route. Number 3 is via blood transfusion or an organ transplant, and the fourth is mother to fetus, where those active tachyzoites actually cross the placenta. All right, Section 3, Pathogenesis and Clinical Manifestations. Let's see the damage. Examiners just love to test the contrast between these two specific patient profiles. If you've got an immunocompetent patient, their immune system usually handles it just fine. They're often completely asymptomatic, or maybe they just present with self-limiting cervical lymphadenopathy, basically some swollen neck nodes. But look over at the other side. In an immunocompromised patient, especially someone battling HIV or AIDS, the infection disseminates. They just don't have the immune response to keep those resting bradyzoids in check, which leads to severe reactivation, most notably in the form of Toxoplasma encephalitis. Okay, pay attention because this is a massive, super high-yield board fact. Toxoplasma encephalitis typically develops when an HIV patient's CD4 T-cell count drops below 100 per microliter. Listen, if you see a clinical vignette with an HIV patient presenting with altered mental status, maybe some seizures, or focal neurologic deficits, and their CD4 is under 100, Toxoplasma encephalitis needs to be right at the very top of your differential diagnosis. Now, what about that mother-to-fetus transmission we talked about earlier? For transplacental transmission, you just need to remember the acronym CHI. When a fetus is infected, they can develop the classic congenital toxoplasmosis triad. That's C for chorioretinitis, H for hydrocephalus, and I for intracranial calcifications. Go ahead and jot CHI next to congenital toxo in your notes right now. Let's transition into Section 4, Laboratory Diagnosis Methods. How do we actually catch this thing? If they throw a slide like this at you on your practical exam, you really need to know what you're looking at. Over on the left, we've got a GM sustain. You're looking for those distinct comma-shaped tachyzoites. Finding those in blood or body fluids is a dead giveaway for an acute infection. Then on the right, we have a tissue section. Notice the tissue cyst containing all those bradyzoites. A really key board detail to remember here is that these bradyzoites are strongly PAS positive. That stands for periodic acid shift stain, by the way. Moving on to antibody detection, which is super common for immunocompetent patients. For serology, just use this simple rule of thumb.
IgM means momentary. It shows up early, usually within the first 1 to 2 weeks, pointing to an acute infection. But what happens if the IgG comes back positive? Well, to figure out exactly when the infection happened, we test the IgG avidity, basically how tightly the antibody binds to the antigen. Low IgG avidity, that indicates a recent infection, something under 12 weeks. Strong avidity means it's an old, remote infection, over 12 weeks old.
Also, do not forget the exceptions because IgG and IgM aren't the whole story here. Use these memory hooks. IgE is your main marker for encephalitis in HIV patients, E for encephalitis. IgA is highly useful for diagnosing congenital toxoplasmosis in babies. And finally, you absolutely must know the name Sabin-Feldman dye test. This is the gold standard complement-mediated neutralization test. The exam question will almost certainly test the fact that it specifically requires live tachyzoites to perform, which is exactly why it's mostly restricted to specialized reference labs.
Finally, bringing it home with Section 5, Treatment and Prevention Strategies. Your instant exam reflex for an HIV patient with a CD4 count under 100 should be prescribing primary prophylaxis to prevent Toxoplasma encephalitis. The drug of choice? Cotrimoxazole, which you might also know as trimethoprim sulfamethoxazole. You keep the patient on this until their count recovers and stays past 200 for at least 3 months on antiretroviral therapy. As for prevention, while since undercooked meat is the most common transmission route, the absolute best advice is cooking meat thoroughly, along with standard hand hygiene, and of course, having pregnant women avoid cleaning out cat litter boxes. As you wrap up this explainer, make sure you can instantly recall that CHI triad and the 100 CD4 threshold for HIV prophylaxis. If you lock those in right alongside our active and Bre-Monix, you're going to absolutely crush these questions on your exams. But hey, before we go, consider this wild fact. Toxoplasma is famous for literally manipulating the brains of mice to make them unafraid of cats. So if it can rewire a rodent's basic survival instincts, what kind of subtle behaviors might it be changing in the billions of humans currently carrying it? Keep studying smart, stay curious, and I'll see you in the next explainer.